Welcome to the presentation on risk management in psychotherapy, social work, counseling, MFTs, etc. I'm Ofer, Ph.D., licensed psychologist, ethicist, instructor, expert witness in courts, author, and most importantly, anthropologically critical thinker. So, psychotherapists, mental health counselors, and social workers are swamped with risk management advice in continuing education courses, bulletin from malpractice insurance carrier, and articles in professional magazine. So the question is, this kind of urge practitioner to curtail those practices that supposedly might result in lawsuit or in licensing board complaint. I will elaborate and explain in this presentation how the concept of risk management primarily serves the insurance company, and generally it neither serves the client or the clinician, or very little at least serves the client or the clinician. In general, risk management advice to clinicians often focus on the following don't with client. Don't physically touch a client. No hug, no touch beyond handshake. Don't exchange gifts with client. Don't self-disclose. Don't text much with client. Don't communicate content online. Don't leave the office or meet a client outside the office. Don't do visits. Don't bother. So a lot of don'ts we have. So in California, for example, risk management have some appropriate advice, and also in other states. For example, don't write custody recommendation to support your patient rigorous or manipulative pleas to get a letter from you about custody. And I fully agree in supporting this important advice. Leave custody recommendation to designated custody evaluators. You are not an expert on custody because you see only the mother or only the father, but you don't see both of them, you don't see the neighbors, you don't talk to the teacher. So no custody recommendation from you, the clinician. Very important. Other important part that risk management is really correct is don't have sex with current or recently terminated client. Don't go into texting late at night, because often texting can be escalating into sexting. So I've been involved in cases where there is literally 2,000 sexting between client and therapist at 2 o'clock at night. It's indefensible. And clients client's attorney can easily access this text of 2 o'clock at night. So no texting at night, because they're so easily moving to sexting. Don't exploit intentionally or harm the client. Don't get involved in complex business venture with client. So this is kind of the basic things that I agree with risk management. And the other thing is, a conscientious practitioner carefully consider the potential risk of any therapeutic intervention. Unfortunately, risk management, the way it's being taught right now and presented in the field of psychotherapy, has several serious drawbacks. The purpose of this presentation is to elaborate on appropriate versus inappropriate risk management advice, the drawback, and to be details, and to expose the seemingly helpful practice of risk management that may have a harmful dark side for psychotherapists and for counselors. In contrast to the endless, frightening, numerous don't messages in risk management workshop and article, it is important to know that lawsuit, and especially successful lawsuit in the field of mental health, are really rare. For example, The annual malpractice insurance costs for MFT or social worker are about $300 or $400 a year. Psychologists paying $1,000 a year. In contrast, anesthesiologists, cardiologists, obstetrician pay, yes, 80,000 or over 100,000 a year in an annual malpractice insurance. So what does it tell you? That it tell you that the risk of malpractice lawsuit against mental health worker is really, really low. Again, compare $400 a year compared to $100,000 a year for some physicians. So unlike the low frequency of malpractice insurance, or lawsuit against mental health, licensing board complaints are much more frequent. So one might wonder why risk management has become so popular, even when the likelihood of civil litigation is so low. This is kind of the questions that I'm posing right now. In my opinion, there are several reasons for that. One, most therapists are risk averse. They come to mental health profession to empathize, help, support, and by definition, they are not great fighters, not overtly aggressive, and are generally conflict avoidance. Therefore, any threat to many therapists seems like highly risky for them, not necessarily weighing how risky it is, the way I mentioned the $100,000 for physician versus $400 for MFTs and social worker. Number two, since the frequency of licensing board complaint is much higher than civil suits, having good insurance coverage to fight licensing board complaint are very, very important. The boards are generally very tight on money, so us choosing the highest level possible insurance coverage for board complaints is really good, smart decision. Please take a note on that. The other reason that insurance companies promote the risk management practice is the cost of defending the rare civil suits that can be astronomically high for them, not necessarily to the clinician, even as high as a couple of $100,000. So then the rare occasion that plaintiff clients win negotiated settlement, it can be easily that expensive. Most legitimate civil suits end up in agreed settlements. They don't go to trial due to the high expense of trial to both sides. So the kind of complex view about the cost. Obviously, it is the best interest of those insurance companies to continue to sponsor risk management seminars. In addition, when the emotional cost to the wrongly accused practitioner is factored in based on realistic or non-realistic fears of losing one's license or losing insurance referrals and the ability to practice, one can see why risk management has become so popular despite the fact the statistical risk of litigation is so low. Fear is a great motivator, and risk management is driven by fear. As I noted above, risk management has changed the field of psychotherapy, making services of psychotherapists less effective and less desirable. One of the core issues in risk management is the concern is what has been termed slippery slope. The term slippery slope refers to the idea that failure to adhere to risk management standards will undeniably lead to harm, exploitation, or foster sexual relationship. The process is described by Gabbard and many others as follows: the crossing of one boundary without obvious catastrophic results, making it easier to cross the next boundary. Oh my goodness. You know, a hug lead to sex and a gift lead to business exchange, kind of is pretty idiotic. Insurance companies view risk management approach as the best means to reduce expenses, reducing the risk of sliding down the slippery slope towards unethical behavioral and harm. A psychologist in the 80s, that was actually the head of the APA committee, popularized the notion of slippery slope in risk management and made a statement that later he retracted, but it kind of stuck with a lot of people. Non-sexual dual relationship, while not unethical and harmful per se, foster sexual dual relationship. So kind of, again, a hug lead to sex. And later year, he really changed his view on that. Of course, these statements have no validity, no foundation, and are unavoidable. Dual relationships are unavoidable in small, isolated community. And as I explained in the dual relationship YouTube that I have, that you can have access to for free, of course, a dual relationship are mandated in military and prisons and are unavoidable also in sports psychology as well in small community. So rigid and inflexible risk management protocol have the following negative effect on clinical work. It eliminates or significantly reduces some effective critical intervention. For example, many therapists kind of become cold and avoid all form of touch. Because of that, therapists avoid appropriate hug, hand holding, encouraging pat on the back. And this is a kind of create a distance between therapist and client and reduce the clinical connection that can help in the relationship, of course. Often it stops therapists also from accepting or giving gifts for relevant, appropriate gifts. When I go to Israel and I come back with some gifts from the Jordan River to some Christian clients, that can help the therapeutic alliance, or give a rock from Jerusalem to a Muslim or Jewish client. So it can really create incredible bond. But risk management somehow have a thing about gift. Similarly, they avoid home visits, which can be really, really telling and important. Risk management is also kind of warn you about bartering arrangement, even though most code of ethics do not. They warn you about don't do too much self-disclosure, but self-disclosure can be highly effective in psychotherapy. That say don't do walk and talk. I call it walk and talk therapy when I walk with a client on a nearby path outside the office. And sometimes calling clients late at night may be appropriate if kind of you pay attention and you perhaps good consultation. Attending a graduation or school play by a very shy child client can be very, very helpful to the therapeutic relationship. Then risk management, paradoxically, rather than decreasing ethic and negligent complaint, actually can increase it. So withholding or being cold or emotionally removed from our client therapists who rigorously practice risk management are more likely to bring negative feeling in clients, which can result in licensing board complaints. So this coldness and distance actually can cause more trouble than it can help. The standard of care is not a standard of perfection, so we are allowed to be mistakes. The standard of care is a C plus standard. It's not an A standard. It's not free of mistakes. So this is kind of very, very important. Risk management, paradoxically, rather than decreasing the ethics and negligence, as I mentioned, complaints, can increase them. Withholding, cold, emotionally removed therapists who rigorously practice the distance and risk management are more likely to bring negative feeling in the client, feeling of rejection, etc., which can result in licensing board complaint. And as I mentioned before, the standard of care is not a standard of perfection. It's not a C plus. It's not free of mistakes. Very, very important for us to remember that. Instead of practicing risk management, fear-based risk management, consider practicing appropriate ethical risk management as summarized in the following. Be fully conscious and aware of the motivation of the forces between many risk management training, articles, books, and podcasts. So when you see risk management in the title, remember this presentation. Be extremely careful and cautious about boundary violation with borderline personality disorder client. Listen to my YouTube or read my articles on You Are One Borderline Away from Losing Your License. They are both on the website as a YouTube as well as an article. Attend to the important concern of what I call the subject and therapy syndrome. I'm going to have a YouTube on that. Consult, consult, and consult. That can get you out of trouble in a more very, very important way. Consult on difficult and complex client. So even if you don't do the right thing and you get consultation and you document the consultation, that can put you within the standard of care of a C plus standard of care, not an A or A minus. Use the information in this YouTube channel and my numerous articles to understand the forces behind risk management. Listen to my YouTube recording at drzur.com on moral junction to help you differentiate between fear and self-serving practices and the ethical clinical intervention that apply to client in order to be ethical and helpful. In summary, our clients do not pay us to practice risk management. They are seeking help in healing and living well. 2, there are ways to reasonably be protective of ourselves, the clinician, without compromising the ethic or efficacy of therapy. And I wish you all good luck.